My final honor for the morning is to introduce our third speaker, yet again, a national, international leader in implementation science, Jonathan Purtle. Jonathan, I did meet for the first time at the Implementation Research Institute. And again, in addition to what you see in Jonathan's published bio, I just want to mention one important contribution. That is his work in really introducing and leading the field of policy implementation science, and the idea that regulation, other policies are not necessarily exogenous. As implementation researchers, we know we can change policies and practices within a health system. What if there's a CMS regulation or a reimbursement policy or some other external environmental factor? If that's the key barrier, then we need to focus on that, not as an exogenous given, that's life, but instead the target of some of our implementation efforts. And that, I think, applies to the work of what you're doing in this room. So again, an important contribution that Jonathan has offered. So Jonathan, the floor is yours.
Thank you so much, Brian. So I am screen sharing here. I can see my screen share, but on the TV I see, on the video, I can't see my slides. Can folks see my screen or no? There's me. There we go. Awesome. Great. Well, I'll get started while that gets squared up. Well, thank you for listening. I'm sorry that I could not make it in person. So I am the booming voice through the speakers, hopefully not too loud. Here I am. And yeah, today I'm going to talk about dissemination research, really, and how it fits into implementation science, and showcase our work and my work of colleagues and I focused on disseminating research evidence about different issues, mainly mental health issues, to policymakers and clinical practice audiences. So, and I'll say up front, the main thing what I'm hoping you all will get from my talk is kind of examples of types of research, types of studies you may consider conducting to improve the dissemination of clinical practice guidelines or other evidence-based practices and programs. So this is what got me really into the field of implementation science. Before I had even heard of implementation science or this word dissemination, I was really interested in figuring out how we could get better mental health policies on the books, especially at the state level. And I was always interested in this, and I stumbled across this article by a mentor of mine named Ross Brownson, who had done these really cool experiments focused on testing the effects of different policy briefs about cancer control policies on state legislators' attitudes and policymaking. And I reached out to Ross and said, hey, will you be a mentor to me in this area? I want to do what you're doing in the area of mental health. And he said, come on in. And this is kind of where I have taken off. So we have the field of implementation science, and implementation science is also often kind of expressed dissemination and implementation research, i.e. D&I. So what is dissemination research? Luckily, there's a very clear definition provided by the NIH. It's a scientific study of the targeted distribution of information and intervention materials to a specific public health or clinical practice audience. The intent is to understand how to best spread and sustain knowledge and the associated evidence-based interventions. So really, dissemination just means communication. I think of dissemination strategies as being a type of implementation strategy, which is really focused on asynchronous, most of the time, communication. So how do you best package and distribute information about evidence? And it's just one strategy kind of within the quiver of implementation science strategies, but it's the one I mainly focus on and the one that I will talk about today. And dissemination research, I think there's a lot of promise for it. So I just want to put this out as an example, something that's kind of always struck me in the area of clinical practice guidelines, right? So when you're developing a clinical practice guideline, it's a scientific approach. It's very systematic, and evidence is really prominent in that whole approach, from identifying the area where you're going to develop the guideline, convening experts, reviewing of the evidence, very systematic, developing the guideline, external review, revision, and kind of the scientific method and evidence is very central to this whole process. But then oftentimes when it comes to disseminating the guideline to the clinicians that you would hope will use it, it's this ad hoc approach, which is really just based on anecdote. Here's a way of putting the PDF together and let's just slap it on and send it out there, right? Kind of the scientific method oftentimes goes out the window. And I think there's much room for improvement in this stage in the process, and this thing called dissemination research, which I will talk a lot about today, I think can help this process. And I'll say up front, by no means do I think more effectively communicating research evidence to target audiences is a silver bullet, but in any way, shape, or form. But I think it's something that we can do much better by bringing in a scientific approach, by bringing evidence and data to inform our dissemination decisions. In that sense, I think there can be some easy wins. So my talk today is going to be structured around this. So I got into the field of implementation science because I wanted to do dissemination research, and I quickly found there wasn't a ton of guidance in the field how to go about this. I'm sorry, something changed, and now there's feedback. There's an echo. Maybe a mic was just unmuted or something. All right, it's better now. Thanks. So we came up with this 3-stage approach, colleagues and I, for different types of dissemination studies one may want to conduct, in the order in which we may consider conducting them. And I'm going to talk about each of these and give some examples across these domains of formative audience research, audience segmentation research, and dissemination effectiveness research. And across each one of these, for the next 15 minutes or so, I'm going to give examples. I'm going to give one example from my own work, which has really been focused on disseminating evidence about behavioral health issues and evidence about health disparities to policymakers. As Brian said, policymakers and policy has been a real focus of mine in implementation science. And also I'll give an example from a partnership with the American Psychological Association, where we use dissemination research to inform their strategies about disseminating information about their clinical practice guidelines. And I'm going to focus on work we did around their clinical practice guideline for PTSD and doing research to figure out how they can better communicate evidence about the guideline to practicing clinical psychologists who treat patients with PTSD. Okay. So first, formative audience research. So formative audience research is really descriptive research. You're trying to understand your target audience, the population you want to disseminate the evidence to, and use this information to inform your dissemination decision. So this would be like very standard practice in marketing, advertising, things like that. So there are at least 4 different things we would want to assess in formative audience research. One is awareness among your target population of the evidence-based intervention that you're disseminating about, or the problem that intervention addresses. Especially with policymakers, oftentimes we have solutions to issues that policymakers don't perceive as problems, right? So first we have to disseminate evidence about the problem and then come with evidence about the policy solution. So this is an example. This was a project done in collaboration with the Robert Wood Johnson Foundation. Robert Wood Johnson Foundation cares a lot about health equity and policy, and they wanted to embark on an initiative to communicate to city policymakers about health disparities. So we did this formative audience research survey of mayors and senior staff across the United States in cities with a population of 50,000 or more. And we wanted to get a sense of, do they agree that health disparities exist in their cities? Do they know that city policies can affect health disparities for better and worse? And here's just what we found. I won't get into the details, but these percentages are way lower than what we thought we would find, way lower than what Robert Wood Johnson Foundation expected. And thus, these data informed their dissemination communication strategies to this policy maker audience. Also, in formative audience research, we might want to get a sense of attitudes towards the intervention or the evidence we're disseminating about. So here are ideas such as Everett Rogers' constructs from the theory of the diffusion of innovations, his attributes of the innovation, things like relative advantage, complexity, trialability. We can assess through surveys and use this information to inform how we frame the evidence and how we disseminate. So this is an example here. The thing we were disseminating about were comprehensive state behavioral health parity laws. So these are laws at the state level. They improve utilization of mental health services by improving insurance coverage for these services. State legislators have the exclusive authority to adopt these laws. We wanted to get a sense, again, through survey-based work, of what they think of these laws, and then we use this information to inform our dissemination strategies and what we emphasize. This is an example from the partnership with APA, with the clinical practice guideline for PTSD. We did this survey and we asked them a range of questions on these 5-point Likert scales. Here we dichotomize it. Did they say 4 or 5 on the scale? Yes, no. What do they think of the guideline? And then subsequent analyses, we stratify these variables by a range of provider level demographic characteristics to just get a sense of our audience and what they think about the guideline. Do they think it's based on quality evidence? Do they think it's compatible with the practicing realities of clinicians? Things like that. And again, we want this information so it can inform how we disseminate. Also, informative audience research, we want to get a sense of adoption of or support for or intention to adopt the intervention, doing the thing. Are they already doing it? Do they plan to do it? Do they want to do it? Things like that. So in our policymaker focused work, we use strongly supporting the policy that we want to disseminate evidence about as being the corollary to adoption. So this is an example in this study. We found that about 40% of state legislators strongly supported these parity laws after we defined them for them in the survey. And then we look at the extent to which these different attitudes towards the policy and other covariates are independently associated with support. And then we use this information to think about what we might target in a policy brief. So for example, this belief that these laws increase access to behavioral health treatments being strongly and independently associated with strong support for these laws. Thus, this is something we might want to emphasize in a policy brief or in our dissemination strategies with state legislators about this body of evidence. Example here from the partnership with the APA. We find that about 40% of clinicians we surveyed said they planned to use the guideline to inform clinical practice. About 10% had already used it. 6% had decided to provide a guideline recommended treatment over another. About 20% had talked with clinicians about the practice guideline. We did this survey about 6 months after the guideline had been put out there by the APA. And again, just potentially important information that can inform how we disseminate about the guideline and evidence more broadly. And lastly, in this domain of formative audience research, getting a sense of how your target audience wants to receive information about the intervention. How do they want to receive the evidence? Do they want emails? Do they want podcasts? What do they want in a policy brief? Things like that. So really basic market research. It's an example here, again, from state legislators in the purple and state mental health agency directors over in the executive branch of state governments in the green. And again, through survey-based work, asking them, saying, if we were to send you evidence about behavioral health issues, how important would it be if it had these different elements, right? So things like providing data on budget impact or cost effectiveness, presenting implications that are politically feasible, things like that. And again, all of this information is just to provide some evidence, some empirical basis to inform how we disseminate, what we disseminate, how we package a policy brief, as opposed to just purely going off of anecdote and what we think might be best. And again, here example from the APA work. Here we provided survey respondents with the opportunity to select all the different ways they might like to get evidence, information about the APA PTSD clinical practice guideline. And you just see this breakout, again, information that may inform dissemination activities. So audience segmentation research. So this is very standard practice in marketing and advertising and in health communication. General premise being, there's this population you want to disseminate to about something, and there's probably a good bit of heterogeneity in that larger population in terms of knowledge and attitudes related to that thing you're disseminating about. So audience segmentation research is an analysis approach which seeks to identify different discrete audience subgroups. And then you think about how you might craft and tailor different messages and dissemination strategies for different folks in different groups who have similar characteristics. So an example here. So again, this is our data from US state legislators. We did a latent class analysis, an audience segmentation study, to try to identify different segments of state legislators who vary in terms of how they think about behavioral health issues, so that we can think about how we might craft and tailor different policy briefs and different communication strategies for state legislators in these different segments when communicating about behavioral health issues. And I won't get into the details, but 3 pretty distinct segments emerged. And the first group, the largest, and I think the most important group, or the group with the clearest implications for dissemination, we found this group that we called the budget-oriented skeptics with stigma. So this group, they cared the most about the economic impact of behavioral health policies. They really cared about the budget and budget implications way more than legislators in these other 2 segments. This group was also really skeptical about the potential effectiveness of mental health and substance use disorder treatments. Small proportions of legislators in this segment really thought that these treatments could work and really help people. And we also found that this segment had the most stigma towards people with serious mental illness. And then we identify non-latent variables such as political party affiliation, gender, their state and their region in the US that are associated with segment membership. And then we think about how we might disseminate and craft messages for legislators in different segments based on this information. Say for the budget-oriented skeptics with stigma, definitely want to include some evidence about cost effectiveness or return on investment. We want to communicate that mental health and substance use disorder treatments can really be effective and can really help people, because they don't really believe that yet. And that's going to be important to garnering their support for policies that would expand access to treatment. And also, we know that the stigma is really prevalent. So we want to be careful in our language and be careful not to amplify stigma towards people with serious mental illness. So here with the APA, we did a similar study with our survey data. And here we put into a latent class analysis, again, variables related to where clinicians turn, where they said they turn for information to inform clinical decision-making with patients around PTSD. So we provide survey respondents with a list of about 10 different sources, say select all the sources where you turn. And then again, we do a latent class analysis, see how these variables hang together. Every person in the sample is assigned a probability of belonging to each segment, and then we assign each person in the sample to the segment to which they have the highest probability of belonging. And the key finding here is this group. Again, the largest group is this group called the no guidelines group. So this group, 0%, the most salient feature of clinicians in this group is 0% of them said they would turn to guidance from a government, regulatory, or professional society, i.e. the APA, to inform clinical decision-making, and 0% of them would turn to guidelines. So this is good to know, right? And then we have these other three groups who vary in different ways, which may be relevant to dissemination. But for APA and for this disseminator of the guidelines, the question is, well, what do we do with this population, right? Do we try to persuade them? Or do we kind of like ignore them because they're not into guidelines anyway, and really focus our energies and our efforts on these other three segments who do to some degree turn to guidelines to inform clinical practice, this being the target audience. And lastly, dissemination effectiveness research. So here we're doing randomized control trials, head-to-head comparisons of dissemination strategy A versus B versus C, and seeing what works best, what's most effective. So most effective at what? We can think about a range of outcomes. We could, of course, look at things like knowledge, attitudes, intentions, and compare those things across the study arms. The con there is you have to go get survey data, right? And legislators and clinicians, very hard to survey, hard to get a good representative response rate. We also can look at behaviors in a range of ways without doing any surveys, right? So most proximally, we can look at things like viewing an email or clicking a link or visiting a website as an engagement outcome and comparing that outcome across the study arms to get a sense of what works best. Lots of folks have also used claims data, right? So disseminate to clinicians in different ways about a specific practice, and then looking prospectively, moving forward, do we see that practice being done more often among clinicians assigned to one arm as opposed to another? And there are a lot of cool examples out there with clinical practice audiences, which I could speak to. So an example from our work, again, here our focus is state legislators. What we're disseminating about is evidence about adverse childhood experiences, things like child abuse and neglect and maltreatment broadly, being risk factors for behavioral health issues in adulthood, because there's a pretty strong epidemiological evidence base saying this is the case. We know a good bit about policies that could help prevent exposure and the incidence of adverse childhood experiences and also mitigate their consequences. And we want to figure out how we can best disseminate this evidence to get state legislators to engage with this evidence and change their thinking and change their policymaking. So this was a 3-arm cluster randomized controlled trial. And the intervention arm, we had economic data that was tailored to the state level. So an Illinois legislator got Illinois-specific information about the potential costs of adverse childhood experiences to public systems in their state, using a range of estimates out there to calculate this. And again, all the data were at the state level, the Illinois level for an Illinois legislator. Then we had this enhanced control where we didn't have economic evidence, but the data was still tailored to the state of the legislator. And then we had the control, no economic evidence, all the data at the national level, talking about the problem more broadly. And what we found that our hypothesis was true, that this intervention condition prompted more engagement measured via email views among state legislators. We find this significant effect. But then when we do effect heterogeneity analyses and we stratify our sample by the political party of the legislator, we found that our effect was entirely driven by Democrats. What we did had no effect on Republican engagement with this evidence whatsoever. And then an example here, finally, from the American Psychological Association, APA, the APA Clinical Practice Guideline dissemination effort. This is a cool study they did that I wasn't involved with, but there is a way in Google Analytics, you can randomly assign visitors to a web page to different versions of the web page. And what they did here was, this is their web page for the Clinical Practice Guideline for PTSD. The text in that orange box was randomized, right? So they set it so when you came to this web page, you were randomly assigned to see one of these messages in the left-hand column there in that orange box. People are randomly assigned, and then they looked at outcomes such as page bounces, right? Did people just leave the website after going to that page? They didn't click through anything else. How long were they on the website? Things like that. And all of this providing some useful information to inform how APA designs this website about the clinical practice guideline. And again, just using some evidence, kind of operating the way an advertising agency or a company would operate when developing a product website to inform how they communicate this evidence. All right, so concluding thought, as I said up front, I don't think by any means that data-driven dissemination and using research and empirical findings to inform how we disseminate is going to be absolutely transformative. It's not going to transform policy or practice in and of itself, but I think it can definitely help. I think it's an area where, again, we are just working based on anecdote, not evidence, and we can use the research method to help inform how we better package and communicate research evidence and clinical practice guidelines to different audiences. So I will stop there. Thank you for listening. I think we have a minute or two for questions.
Yeah, hi, Dr. Purtle. Mary Nix from AHRQ. Thank you for that presentation. Our agency is all about dissemination, and so I dig what you've been doing. With regard to your presentation, you asked the question, but I didn't hear the answer of what and this is in the portion of the audience segmentation research. You identified that group of the no guideline group. And you asked the question of, well, what do you do with them? They're not looking for the guideline. They're not accessing the guideline. They're not interested in the guideline. They're getting their information from other sources. So your question was, well, what do we do with them? Do we ignore them and go and target our work to the other three groups that are using guidelines to some extent? And I think I might have missed your answer of, well, what did you do?
Yeah. So absolutely. And that I'm not exactly sure what precisely APA did to with that group. I think an important consideration, and I'll say right now, I don't know what we did with the group, and I don't have an answer. And I think it depends when you have a group like that. So I think one important consideration was if we look more at that group, are they already practicing in guideline concordant ways, right? And if the answer is yes, by and large, or to a similar degree to clinicians in the other group, yeah, maybe we don't put in extra effort to tailor a strategy for that group. But if they were practicing in ways that were very non-guideline concordant, I think we want to get a better sense of why, and get a better sense also of why they're not turning to guidelines, and also more broadly, like why they wouldn't look to a government or professional agency or professional society to inform their decisions. Unpack that in greater depth to inform decision making about if and how we target efforts to that audience.
Thank you.
Thank you for the question.
Hi, Dr. Purtle, Alyssa Johnson, Trauma System Manager for Montana. And going back to your political views, Democratic, Republican, I come from a very heavy Republican state. In dealing with the legislature, do you have any suggestions on how to engage the Republican Party since you said it, your information really made an impact on the Democratic side, but not the Republican side.
Yeah, so a couple thoughts. So prior research that we had done, that others had done, again, kind of looking along party lines and looking for differences, we found that Republican legislators cared more about economic evidence and stuff like return on investment. Thus, we actually hypothesized this intervention group that we, again, emphasized economic evidence would be more effective among Republicans, and we didn't find that at all. So my hunch is that it was the source of the dissemination, which is the reason we didn't see any effect. The source being me, a university researcher based on the East Coast. So we know that often as more conservative legislators are more skeptical of academics, perhaps especially those in the Northeast. They're kind of seen as elitist and out of touch. And I would have a hunch that if we did the same study, but manipulated the source. So say it was from a industry related source, or maybe even a professional organization related to behavioral health, we might see more of an impact among the Republicans. So I think source is something I didn't talk about much today, but source matters a ton as well, right? How credible, how trustworthy is the source perceived, and that affects engagement with evidence that is disseminated.
Thank you so much. Thank you for joining us from your vacation with your family. We really appreciate you doing that.
Cool. Thank you for listening. Bye-bye.